people with a total positive percentage of 17.5%. At Baptist Memphis, we've tested 71,547 people with a positive rate of 10.9%. And then looking at hospitalization data for right now, numbers are thankfully trending down still. There are 65 people at Baptist Memphis in acute care non-ICU beds, and there are 35 people in the ICU with COVID, both those numbers with COVID, for a total of 100 even. So this is the first time we've been down potentially to get below 100 for quite some time. Our peak on this wave had been 152, remembering that the peak at the maximum wave initially had been 172 previously on the last surge. Of those 35 in the ICU with COVID, 27 of the 35 are on ventilators. We have 80 ventilators currently in the facility, and 56 of those ventilators are in use with all comers, obviously not just COVID. There are 4 people out of those 100 currently in-house who are fully vaccinated. And of the 9 admissions we had in the last 24 hours, none of them had been fully vaccinated. If we look at Baptist DeSoto, there are 74 people in acute care non-ICU beds with COVID, and there are 14 people in the intensive care unit with COVID, for a total of 88 people at Baptist DeSoto with the infection. 10 of the 14 people in the ICU are on ventilators. They have 53 ventilators currently at the facility. Only 17 of those 53 are in use by all comers. They have 3 out of those 88 people in-house who are fully vaccinated, and of the 10 admissions they had in the last 24 hours, only 1 was fully vaccinated. So the trend, very helpful. It's dipping down to numbers that we haven't seen for the past few weeks. It has given us a bit of breathing room. It's allowed us to even transfer some people in from other hospitals in a couple of instances for both COVID and non-COVID circumstances. So we certainly hope that this trend will continue, though. Obviously, the trend nationally of deaths is not coming down yet, because that is lagging behind our rate of cases and hospitalizations even. And there's still a large number of people in the ICU with this disease. We still have a fairly high number of those folks. And that's been the characteristic, as we've said many times, of this wave. It's younger people. They tend to stay sicker longer. Even when they don't survive the infection, they are in the ICU for a much longer period of time. But total, getting a little bit of breathing room in the total numbers that hopefully allow us to see some other people with other illnesses as well. So happy to answer any questions if there are any.
Hey, Dr. Threlkeld, it's Corinne.
Hi, Corinne. How are you?
I'm all right. Enjoying the slight cooling off of the weather. Hopefully we're into our 2 weeks of fall. So
it's pretty much 70 and fluorescent where I am.
Okay. Well, minus the fluorescence, it's about the same outside. So you mentioned, this good continuation of the dip in hospitalized COVID-19 patients, but do you think this decrease has been prolonged enough for us to really say we're on the other side of this surge, that we're on the other side of the bell curve, or is it too early to make a statement like that yet?
Well, there's several caveats, obviously. We were a lot better off than this, down at 10 people in our hospital when we got to the real lull after the previous peak. So obviously we have to be very careful. There is not, as far as we know, a threat like Delta was, as it was literally burning through India and causing a lot of cases and leaving the cities really in turmoil there. And even as we were sort of celebrating our improvement, they were in a pretty tough situation. We don't see anything actively like that. But again, we have a lot of improvement to go before we get to a point where we even were last time. I think the things going against us here are that we're going into the fall and winter where people will be more and more inside, drier weather. That helps the virus. Even though it didn't go away last summer, it came back pretty strong after the summer. So obviously, there are still, as we accumulate people who've had the infection and who have had the vaccine, Delta will become less impressive. The problem is that all of those unvaccinated people and uninfected previously people are still targets. And this virus, as we have seen a lot, seeks them out with a fair amount of efficiency. So all across the country, even in places that have high vaccination rates, there's still 30% of the population that hasn't been vaccinated. So we might see other pockets of heavy infection, even in other places in the country. And again, still, there are a number of people in our region who have yet to be vaccinated and even yet infected. We don't know exactly what the infected number really is, I don't think. But there's still enough people there to cause a great deal of difficulty for themselves, obviously the danger of it, and then to congest our healthcare system. I mean, obviously, I feel a lot better about it with nothing clearly on the horizon. I think we've mentioned several times the fact that up to now, it's always been a new variant coming along that was more contagious, that would just simply outpower the previous variant and just infect more people faster and literally choke it out. Whereas this time, as more people are getting infected with any of the variants, including Delta, it may not be that being more contagious with the next variant is going to be the advantage that it has been up to now. As more people are protected either through natural immunity or vaccination, it may be variants such as Gamma, maybe Mu. We don't have on the ground data on that yet, but just from the profile of mutations, or some variant that we don't really even know about yet, those could be more resistant to our immunity. Those would be the ones that might filter in and sort of sneak in the door and begin to infect people. So I'm optimistic. I was optimistic last time, though, but certainly we hope that with nothing clearly on the horizon with a variant of significant concern, that we'll see the numbers go down. But again, there are enough parameters that work against us that we have to be very careful about that sort of optimism. So, I mean, the order of the day is going to be to continue to vaccinate the best we can. And certainly we are yet to face a continuing problem with the healthcare system, the deaths. We're up to 2,000 deaths per day right now in the U.S., which is over 14,000 per week. When you compare that to previous numbers in July, in the last lull, it was a little over 1,500 rather than 14,000 deaths per week that we have now. Still a very large increase in cases that we're seeing daily compared to what we saw in the sort of the nadir that we had through the summer, but it's going down. But the deaths may continue on, for some weeks. I mean, we're up to 678,000 plus deaths in the U.S., over 4.7 million deaths worldwide. So it is very, very difficult to underestimate what this virus can do. We hope that the combination of what we're doing with the vaccine and simply our immune experience with the virus is at least limiting its options and its capability to infect us, at least for more and more people. But the people who are unvaccinated, this does not help. Only in the point that the total number of cases and the transmission in the community may go down because of all that, and that may be helpful to those folks. But if you're unprotected, you still face essentially all the dangers of that virus.
And you mentioned the general trend you're seeing with hospitalized patients is the ones who do get really sick, they stay really sick for a long time. Do you have an estimation, and I'm sure there's a lot of variation, of what is kind of the average hospital stay, the average length of hospital stay you're seeing right now among COVID-19 patients?
Yeah, it's a tough question for me. I spend a lot of my time in the ICUs, and so I tend to see the worst of it. But it's so variable. It varies with the immune status of the patient to begin with, whether they had been vaccinated or not. Someone who's immune suppressed may not have gotten much protection. So there's so many variables, but we certainly see when people come to the hospital, it's generally because they need oxygen and more intensive care. We tend to, if they're needing oxygen, come in, start them on some other medications, certainly steroids, and in a lot of instances, remdesivir. If they're not needing a lot of oxygenation or a lot of oxygen support, we may not start those immune modulators like the tocilizumab and the like, baricitinib, those sort of modulating medicines that prevent the lungs from being as damaged by our immune system that have sort of run amok. So a lot of people that get here will stay a few days simply because you want to make sure they're at least stable and not getting worse. And probably the length of stay in the hospital is it's a little longer than it absolutely might have had to be, because we are appropriately, I think, a little bit gun shy, having watched a lot of people go from a couple of liters of oxygen to 10 liters of oxygen in a matter of hours. And so we've seen this enough times where we're very nervous when somebody comes in needing oxygen already in the hospital. So what typically has to happen before they go home is they need to stabilize and even improve and get the oxygen levels down to 1 or 2 liters before we really feel comfortable that they're not going to get worse again. And then we can finish the job at home with good home health support and family support and the like in that situation. So when you get here with COVID, it's usually not a 1-day or even a 2-day affair in a lot of those circumstances. If you get to be that sick, we need to do some things that might take a couple of days to make them better. So that's one of the things that's kept people in the hospital a bit longer for this kind of thing, just innately, because they can just go over the cliff so quickly. And so we have to watch them a little more carefully. Any other questions? I will answer a few off the feed then from last time. There's certainly a lot of issues going on right now. Let me get back to the first page. Amber Stewart asks, why are the different variants mentioned when the tests aren't variant specific? And a good question. We don't test for variants routinely anymore because essentially all of them are Delta. And because it doesn't change what we do for an individual patient. It really only matters that they have COVID in the first place. And so the variants really tend to be more a burden for the public health authorities to find out what variants are in our community. Because if there is a sudden rise in gamma variant or mu variant or the like, that can change our perspective on what we have to do from infection control circumstances, because those things might have more resistance to our immunity, both vaccine generated immunity and natural immunity. So we don't routinely do them, but the health department, and sometimes we do too, if it's an unusual circumstance or travel related, we will go ahead and check the sequencing for those variants, which we can easily do. We just don't routinely do them because of those other reasons every day. Taran Henderson asks, if you're immunocompromised, fully vaccinated, and had a breakthrough case, should you still get the booster? If so, when, and how long afterwards do we wait? Well, that is a very, very difficult question, and one that I think we don't really have a very good answer to. If you're immunosuppressed and have been fully vaccinated, you still have to, as we've kind of mentioned a bunch of times, you have to consider yourself not as protected as you would if you had a normal immune system and had been vaccinated. Your breakthrough rate is going to be a lot higher, and so you have to be a lot more careful, I think. So if you have a breakthrough case, on top of that, that is about as protected as you can be if you have a normal immune system. That is to say, have a case, a real case, and the full vaccine. That immunity seems to be as good as we have been able to measure under any circumstances. Whether a booster on top of that situation in your case would be helpful or not, we simply don't know. And I think there'll be more data about that as we come out. But it's been hard enough to study just somebody who's been vaccinated without a case, or whether a booster helped or not. So I think we're going to have to wait a little bit longer to have that answer. It's a great question. I think we just don't know statistically. And that's the kind of thing that you should check with your own provider. Let them look at your own situation. And even still, it'll be a difficult question to answer, but they can consult with people and try to come up with an answer that is really tailored to your situation. Iona Jackson asks, if I'm immune compromised and have had COVID on top of the vaccine, do I need a booster? Similar question. I think same answer. We really don't know the situation. If you're immunocompromised and have COVID and have been vaccinated, again, that's a situation where we just don't have enough data to be able to answer the question very well. And we see a lot of people, I was talking earlier today, people who are kind of taking matters into their own hands and going out, for example, and getting boosters in groups in which they're not approved. So non-immunosuppressed people below 65, that sort of group, a lot of people have gone out and gotten those vaccines. The problem is that we just don't have the data yet to show that it's worth it to do that. The safety, efficacy sort of pendulum, we don't know where it really falls. And it's unfortunate because, as I say, the same people who are criticizing other people for not following the science and not getting the vaccine are then sort of marching out and getting ahead of the science. So I think it's very difficult to it's very difficult in that situation. People sometimes make the science what they want it to be. And so you have to be careful on either side to get ahead of what the data really tell us to do. And you have to be careful. As I was talking to someone else this morning about it, we found this out in pregnant patients. We didn't know at first whether it was okay to give the vaccine to pregnant women because they just weren't a part of the trials initially. And so we kind of said, look, talk to your doctor, talk to your obstetrician, and we make a decision based on other factors until we get the data. Well, it wasn't long before we had the data and it found out you're much safer getting the vaccine than you are trying to go it alone through pregnancy without the vaccine. So, but we needed to wait for those data before we answered that question, and so we did. So in a lot of these situations, it's the kind of thing where we just have to wait for a little more data before we can really know, I think. Tiffany Mosley asked, how long will it take to get your taste and smell back? Very variable. Some people get it back quite quickly, even before they're completely well from others. Some people it has lasted out a year. Thankfully, most people have it recover over just a few months. But obviously, there's a wide range of that, as there are in other parts of the long COVID syndrome. And so those symptoms can be pretty variable in their, in their duration. Libby Nicholas asks, what aggressive, quote, aggressive, unquote, treatments are being given to those hospitalized and in the ICU with COVID? And are the vaccinated and unvaccinated being given the same treatments if they are in the same condition? The second part of the question I'll take first. Yes, vaccinated and unvaccinated people are absolutely being given the same treatment for the same condition. So the condition you're in, how you're presenting, what your oxygenation is, being a prime determinant of what therapy you get, that is the same for us whether you have been vaccinated or unvaccinated. One of the things that really makes me mad is when people somehow give the impression, or there are articles out there that say that people who are unvaccinated are going to be treated less aggressively and we're going to push them to the side. That is ridiculous. We do the best we can for everybody. We don't try to decide who deserves something and who does not, because before you know it, you will have disqualified yourself, no matter who you are, from the best treatment if you have that sort of take on things. So the treatments are in fact the same for at least once you get sick enough to be in the hospital. There are some exceptions before you get sick enough. Now your question has to do with ICU, in which case, as I say, they're the same. Before you're hospitalized, if you're unvaccinated, you would be eligible for preventive or prophylactic therapy with the monoclonal antibodies. And there's the whole question of the state and NIH recommending that people who are fully vaccinated not get that monoclonal antibody. We've already looked at that issue with people who are just wanting it for preventive purposes. If you're fully vaccinated, there was no emergency use authorization for you to get it as a preventive. Certainly, it was still authorized as a treatment once you get it, once you get the infection. But if you've just been exposed to somebody and you're unvaccinated, it is an emergency use authorization approval for you to be able to get monoclonal antibody just because of that exposure if you're high risk and unvaccinated. I'll just mention briefly the sort of controversy over whether people should get the monoclonal antibody if they're fully vaccinated. And you've seen this range from the political to the medical. The political end of the discussion was a seeming disagreement between the president and many governors in the southeastern region. And the concern was that southern governors were not pushing the vaccine enough and utilizing monoclonal antibodies as sort of a substitute for the vaccine. Obviously, you can imagine there was disagreement on whether that was really happening. But the problem was that a substantial percentage of the monoclonal antibody supply for the country was being utilized in our region in the Southeast. And so there was a fair amount of discussion about that. And there was concern that that would really deplete the national supply of the monoclonal antibody, which is shown to be quite effective. And so there was appropriate concern about that. And though certainly I get it, if somebody from Connecticut needs a monoclonal antibody 6 months from now and can't get it because another region of the country utilized most of what we had, and they were utilizing because nobody got vaccinated per recommendations, I can see how that would be irritating. However, as a healthcare worker, we don't like those sorts of problems. We try to treat the person in front of us. I don't think we're barred from using the monoclonal antibody on vaccinated people. I think we just have to be careful because the NIH has already given recommendations about what to do when there is a shortage of these things. If that is the case, there is a shortage of monoclonal antibodies. We have to be careful how we utilize it, and we utilize it in the people who are most likely to benefit from it first. Any of the triage sort of principles in that regard. So I think that We do have to be careful how we use it in a limited resource, but every patient is different. And so an 86-year-old person who was vaccinated in January is of a different risk from a 28-year-old person who was vaccinated 3 months ago. Certainly the older person is at great increased risk, but if fully vaccinated and there was a significant shortage, might not qualify. As I say, I think it's still being left largely in the hands of providers, so we still are able to give the monoclonal antibody to vaccinated people if we deem them at high enough risk and it's appropriate to do it. And I certainly think you'll see a lot of that sort of distinction being made along the way. I would say one other thing that's actually an interesting piece of news that has come out, I think just today. Gilead announced a study that's not been peer reviewed yet, but they pointed out that a 3-day course of remdesivir, a drug that heretofore had only been approved to use in the hospital in somebody requiring oxygen, but a 3-day course of IV remdesivir actually cut the rate of hospital admissions when given early on in disease by 87% and the death rate by 81%. And that's a pretty stunning number. It is on par or higher than what we see in the monoclonal antibody. So it may be, if this pans out after being kind of reviewed by peers in the field, and it's going to be presented at a national infectious disease meeting next month, if that really pans out, this drug is already approved for inpatient use, fully FDA approved. So you actually wouldn't need another emergency use authorization to utilize it as an outpatient for a 3-day infusion, much like we're doing with the monoclonal antibody, only a 3-day rather than 1-day kind of dose. So if that pans out, it would be something that appears to be, preliminarily at least as effective as the monoclonal antibody. So that's kind of an exciting development, along with those oral antivirals that are also in the pipeline in phase 3 trials now, like molnupiravir, one of the Merck drugs. There's several options here that are going to be potentially available for people earlier on infection. And that, after all, is the best way to do this, is to treat people early on so they don't need hospitalization and get into that sort of situation. Several fairly exciting things going on early on in disease like that. Briefly, Sandy Brunson asked, can you explain monoclonal antibody infusions? What is it? Is it offered to everyone? And if so, why are people dying? We kind of just a minute ago mentioned kind of who is it available for. And it does cut hospitalization and death rates for people who get the monoclonal antibody, but remember, it's only available within 10 days of the onset of your symptoms. It's only an early therapy. Antivirals in general, and in here the monoclonal antibodies in particular, they really only work early in disease. After you get sick and are hospitalized and needing oxygen, you're kind of past the viral stage of the disease per se, with some variability, mind you, but you're largely into an immune phase where the immune system is mistakenly firing off all of its guns in its own bedroom or living room and damaging itself and its lungs associated with it. So really these antivirals are best given early on in disease. So what these monoclonal antibodies do, in just the briefest description, is they have their Y-shaped little proteins. They pour in and they stick to the places on the virus where that virus would attach to your cells and infect you. It essentially gums up the works of the virus as it tries to infect our cells and puts it out of business. It's a so-called neutralizing antibody. It neutralizes the ability of the virus to infect our cells by sticking to those key areas on the spike protein. So that's really what it does, but we have to give it early on in disease, as we said, as opposed to the remdesivir, which we've been giving a bit later in disease. That's where its approval is, but now we're finding, not at all as a surprise, that it has terrific benefit early on in infection, at least according to the data that have been released by the company. So we'll see how that pans out over the next few weeks. Amelia Cole asked, my nephew's neurologist told him not to get the shot due to his having a shunt in his head that was used to drain fluid when he was younger. Your opinion? Wouldn't want to comment on any particular person because there may be some element that we're not connecting on for them not to get the vaccine, but I can tell you there are precious few reasons not to get the vaccine in this world, and I would not list, in my own opinion, as an isolated reason any sort of previous neurologic problem, and that would include hardware. So I would look to that physician for another reason in addition to that not to be vaccinated, because I would think that we'd need to have something else involved to make such a recommendation. A very important question, Lauren Wilkie asks, if I've had COVID in the past, should I have my antibody level checked before getting the vaccine? And the answer is absolutely not. This is one of the largest mistakes that I see made. We've talked about it briefly before. People have had COVID and they think their immune system is absolutely fine. I have seen quite a few people die making that mistake. They think they don't need any kind of boost. Very good data now have shown that you can have 2 to 3 times improved protection if you get the vaccine on top of having had the infection in the past. That is a crucial thing for people to remember. I'll say it again, have seen several people die from making that mistake. And they're very confident, people are, when they tell me my immune system is fine. And I say, well, there are great examples where that's not right. And are you really willing to bet your life on that in a situation, particularly if you're a high risk sort of person? The antibody levels that we draw on people are very much less and less being utilized and less needed. We check antibodies, we don't really know what they mean. We've never had what we call correlates of immunity. That is to say, a certain level of antibody above which you are protected and below which you are not. We don't know what that is. Total antibodies is a neat measurement. It can tell you, if you check the right antibody, whether you've had the infection before. It can help us determine that. But you don't know how many of those particular antibodies that you're measuring are neutralizing antibodies. You may be shooting antibodies that aren't very effective at hitting the target and bouncing off the most important parts of the virus. So we just don't know what an antibody level of 180 versus 98. We just don't know how to compare those things. So it is not recommended that you check an antibody level to determine whether or not you need a vaccine. I'll say it once more. Do not check antibodies to decide whether you need a vaccination. You should get it anyway, because you can't really count on the level of antibody that you're measuring to tell you that you are in fact immune. Where it sometimes helps is, we were measuring to see if anybody had any antibody at all. If you don't measure any antibodies, it's a fairly good idea that you don't have much immunity. And so you need to be very careful. Again, not that you shouldn't be careful if you're immunosuppressed, even if you have antibodies. So a very, very important question. Thanks for that. A couple of more, if there are no other questions. Somebody interrupt if they have any, please. Nancy Wallace, what are the most common symptoms of long haulers, and are there a lot of people experiencing long haulers? There have been varying studies showing how many people have had so-called long haul syndrome. A lot of people. Some studies say 20, 30% or more. They can be everything from just the longer duration taste and smell problem that was asked about earlier, to foggy headedness, so-called brain fog. There are neurologic issues. There are endocrine problems. One common one that's a special kind of long haul is somebody that just had enough lung damage. They recover. They didn't die of the infection, but they have damaged lungs that will stay with them the rest of their life. They'll be short of breath, cough sometimes, and really have decreased exercise tolerance. We've seen a lot of that. And in addition, we've seen people be short of breath and feel bad and very weak for weeks on end or longer, even if there's no ostensible, structural damage to the lung that should keep those symptoms going. So we've seen a lot of that. It'll still be time before we really are able to hash out how long the average symptoms last, but they are many and varied. There are several articles that you can look up that show the extent of the different types of those situations, and there are entire clinics that are going up now to deal with long haulers, and it's something that we're afraid will be with us for quite some time in dealing with those kinds of problems. Just running through a couple of more. Michelle Jackson asks, I'm a cancer, stroke, and heart patient. Can I get the booster? Again, a very good question that gets into the gray area. Exactly what constitutes more likely high risk to get the booster is something of a slightly fluid issue. Clearly, if you're over 65 and are more than 6 months after the vaccine, that's what's the question that's facing the FDA right now. That's likely what is to make it through in the first stage of approval for the booster. If you've had cancer, you may have had chemotherapies that would impair the immune system. You may have had cancers like blood-related cancers, lymphomas, and leukemias that might make you immunosuppressed intrinsically too. So some people will make it over the barrier to get the vaccine just based on those underlying illnesses. The heart disease, not so much. It would qualify you for a monoclonal antibody treatment, but not necessarily for a booster. I expect that will be changing, and that the FDA and the CDC will be looking at increasing groups to get the boosters. That's likely to be what we see over the coming weeks. So it's kind of a firm maybe. That's the kind of thing to check with your primary physician about, I think, as well. But some people in that situation might well make it into getting a booster. April Stewart asked, can you tell what the bed capacity is? Can someone get care with a non-COVID health issue? Goes back to the very first mention of the numbers today. The bed capacity is adequate right now. Our numbers of COVID cases are down just enough to give us a bit of breathing room. I mentioned I've had a couple people transferred in, mind you, for other problems. So that kind of answers the second question. A non-COVID health issue with some serious lung problems just got transferred in yesterday. So we are able, I think, better to deal with. We've never gotten to the point where we couldn't take care of people like you've seen in some of the hospitals in Louisiana and other places, but we've gotten close enough where you could see it from here, and those kind of things make us very nervous. But we've pulled back quite a bit from there, so I think our capacity is quite a bit better now. Kara Redding asked, how long does the immunity last? And that's the million-dollar question, and really the basis behind the concern for boosters, whether or not we should get them. The Israeli data suggests that after 5-6 months post the vaccine, things start to dwindle. The question is, how long does the immunity last to prevent more serious disease, hospitalization, and death? And it seems, at least so far in the United States, that protection has been maintained from the virus. So I think more months will have to go by before we have a very good handle on that question. Furthermore, it's important to know that these vaccine trials that we're looking at with boosters, probably all of the makers are looking at these data. Clearly, Pfizer is. It's already kind of presented their data and are in the process of applying, to the FDA for the kids' vaccine and other things. They're keeping track of that. They're keeping track of how long the boosters last. So how long immunity lasts will be an ongoing question that cycles with every booster we give or every change that we give and how we vaccinate people. So that will be a very fluid question that we have to continue asking over time. A couple of more. Can you, Ashley Ludlow asked, can you please discuss the importance of those that had COVID in the past getting the vaccine? I think that's kind of what we talked about a minute ago. Very important to get the vaccine, 2 to 3 times the protection, and why not give yourself that protection and also the protection from getting it even less symptomatically and giving it to others. So all those things I think are reasons to push ahead and get the vaccine, even if you have had it. Some people say, well, the Israeli study said that you have better protection from a natural infection than you did if you get the vaccine. And that may well be true. We don't know for sure. That study had a few things that need to be looked at about how much more protection. But if you're standing here vaccinated or unvaccinated, if you're standing here unvaccinated, previously infected or not, both parties can get substantial increase in protection by getting the vaccine. So I think that's the recommendation from both of those groups. Beth Hall Kargauer asked, do you think the booster shots will be in a different dosage from the first two? The Pfizer is the same. The J&J test, I believe, was the same as well. But the other is actually at a half dose. The Moderna vaccine booster is being tested at half dose. So we'll see how that plays out. And finally, is it true that this is from Isaac Kike, is it true that the booster shot can cause myocarditis? And the answer to that is actually, that's a timely question as well. Yes, any vaccine can lead to myocarditis. It is pretty clear that there is a very small risk that is increased of myocarditis with any of the COVID shots. Most likely so far with the second shot, it's unclear yet. We don't have enough data about the third shots to know what that risk is compared to the first and second. Presumably the second will be the highest risk, but there's some increasing data coming out now, some published in the New England Journal of Medicine, showing that the risk, very small though it is, of getting myocarditis related to the vaccine is substantially 5-6 times lower than getting myocarditis from the infection. So once again, we see something that is put out there as a reason not to get the vaccine. But when you really look at the data and hash them out, not only is that it may be slightly true that you have a little bit of an increase, but everything is relative. You have to go with the numbers here. And the numbers suggest that you are significantly more likely to get that very same problem that you're worried about if you face the vaccine alone if you face the virus alone without that vaccine. So the vaccine is, yes, slightly predisposing for myocarditis, but it protects from a much larger risk of myocarditis. It is the principle that we don't manage risks very well in our human brains. We are set up to avoid risk number one. But what we have to remember is that not going through door number one necessarily catapults us through door number 2, which is the risk of getting it with the infection per se, which is significantly larger. Our brains never make it to door number 2. We only say, gosh, I don't want to take that small risk of myocarditis by getting the vaccine, when in fact you are actually saving yourself from a much larger risk. So an important thing for people to remember as they look at vaccine numbers in general, because it's a mistake that many people have made and caused them not to get the vaccine when in fact that would have been the right thing to do statistically. We operate and again, in our human brains, not by the numbers. We tend to operate on our emotional response to numbers. And that is not necessarily the same thing in terms of statistical success. You want to go with what gives you the best chance of being alive and well a year from now, not what somebody's reaction is, where your brother-in-law's cousin says that they had a bad problem with the vaccine. That may be true, but you can still at the same time be a lot less likely to have that same problem by getting the vaccine than if you don't. And in that sense, what happened to one person out there is truly irrelevant statistically in deciding what you would do. So thanks for those questions. Any other questions I can answer?
Yeah, I'll jump back in with one more. I'm sorry, I didn't want to interrupt you earlier. You were kind of on a roll. About going back to the monoclonal antibodies, we're obviously using them at a really rapid rate just because of the nature of this surge nationally. But, why, other than that, why is there a shortage? Is it something that takes a long time to manufacture? Can you kind of talk us through that? Why can't we just keep pumping more out?
Yeah, no, good question. And I don't have a great answer because I'm not sure that I've really delved into the into the supply chain issues with the company right now. I will say this: it's been very up and down. I mean, obviously, when we first came, and we again were, I think, the first place in the country to give it at 8 a.m. the first day it was available. We built out rooms to give it, and there wasn't much uptake at first. We really didn't get a lot of people giving it. We ramped it up. We've always been fairly optimistic about that therapy, and as more data came out, it looked better and better. It's what the president got, President Trump, that is, when he got the infection. And so I think, interestingly, as the Delta wave came, we saw a lot of increased desire for the monoclonal antibody, and a lot of them really were people who were unvaccinated. And it was a strange phenomenon that people who were unvaccinated and didn't want to be vaccinated, thought it was risky, were very happy to reach for a monoclonal antibody that had a lot less data associated with it. I was up on it. I thought it was great. I thought they were good data, but a lot less than the vaccine per se. So again, it's one of those statistical anomalies. People didn't want the vaccine, but reached for something a lot less proven because it goes back to that adage that I like to point to, and that says if you feel fine, you don't want to do anything because you perceive that as risky. If you're sick or feel bad, that's different. You, by golly, want something done right now. And so people are just, I think, more psychologically compelled to go get a therapy if they're already sick and feeling bad. So we had a big uptake then, and I don't think, we're not out of we have not had any problem getting people monoclonal antibody at our system. We've had plenty to get the job done right now. But I think the problem is that with this surge, we are just using it all of a sudden a lot faster than was anticipated. So I expect that it's just a matter of they are indeed ramping it up. I know the federal government has bought a fair amount of it, or at least rights to get a lot more of it. And I think they are ramping up production. But as usual, when you have a rapid increase in demand, sometimes that production lags. And I think the concern is not so much that we can't meet the demand right now, but that if Delta then spreads again around the country in some other pockets, like it is likely to do, into other pockets of unvaccinated folks, or to filter along at a rate through even fairly high vaccinated states, but in pockets within those states, there could just be a significant continuing demand. So yeah, I think it's a matter of a concern that we're going to get to that point soon, that we won't have enough. And obviously there's been an argument that we in the Southeast, with a fairly low vaccine uptake, are utilizing this now that we're getting sicker collectively just by the numbers, that we're taking more than our fair share of the national supply. And I think that there's certainly, you can understand other states being concerned about that. So the federal government has kind of stepped in and said, okay, we're going to control a bit how many each state can get. And so Lisa Piercy and other folks at the Tennessee Department of Health have said, look, it looks like we're going to be limited in our supply. So we're going to begin to follow already the NIH guidelines for what to do if you are in limited supply, because it looks like that might happen. And part of that is to give it only to unvaccinated people as the higher risk folks. So I hope that they'll be able to ramp up production, but it's a great question. I'm not exactly sure how quickly they can reach that capacity. Any other questions? Okay, thanks very much.